Okay, welcome everybody. For those who do not know me, I am Michael Berg. I have the distinction of being the first epilepsy fellow at the University of Rochester, trained by my dear colleague and mentor, Giuseppe Erba. Today, I have the honor of introducing the very first Erba and Persinski endowed lectureship in functional neurology. Giuseppe Erba is the father of the University of Rochester Epilepsy Center. He was recruited from Boston in 1989 to start our program. From the beginning, Giuseppe recognized that many people with epilepsy struggle with their mental health, family, and social life, and that about 1/3 of people with intractable seizures actually do not have epilepsy, but have functional neurologic disorder. Along with developing a leading epilepsy surgery and anti-seizure medication treatment program, since our inception, Giuseppe emphasized the need to address behavioral health issues of our patients. For example, in 2003, along with one of our postdocs, Giuseppe published remarkable findings on sudden health, which described how family dynamics directly affect the outcome of people who become free of seizures with epilepsy surgery. And based on this finding, we changed our psychosocial pre-surgical planning process. Giuseppe also championed and was co-PI on the landmark Early Randomized Surgery in Epilepsy trial, ERSET, which demonstrated the importance of early surgery in intractable epilepsy to obtain the best quality of life outcome for our patients. Giuseppe has had a particular focus on patients with FND, which in the epilepsy world present as psychogenic non-epileptic attacks that we term PNEA. Giuseppe stressed the importance of a strong psychosocial team with psychologists, psychiatrists, and social workers working in concert with the epileptologists to care for patients with PNEA. More recently, Giuseppe has built several research groups focusing on alternative ways to differentiate epileptic seizures from PNEA by using questionnaires, video, and autonomic measures. The UR Functional Neurology program has evolved out of Giuseppe's early efforts. Our neurology and psychiatry departments have developed a strong relationship to provide care to patients with FND. Our program now offers one of the first ever fellowships in FND, and we are currently training our third fellow. I think it is fair to say that the strength and progress of our behavioral health initiative was inspired by Giuseppe's leadership and legacy. One of the early recruits in the Epilepsy Center psychosocial team was Bill Watson. Bill received his BA in psychology at Princeton in 1975, and he completed his master's and PhD work in clinical psychology in California in 1986. In 1987, he completed a postdoctoral fellowship in family therapy here at the University of Rochester. He then joined our faculty in 1987. And in 1996, we were very fortunate that Bill became the Epilepsy Center's family psychology consultant, a role in which he continues today. One of Bill's major contributions has been the introduction of teaching of the emotional-based therapy approach, intensive short-term dynamic psychotherapy, or ISTDP. Bill has achieved expertise in this area through advanced training with Alan Abbas in Joel Town in Halifax, Nova Scotia. For the past several years, Bill has organized annual conferences, often featuring Dr. Abbas, to increase the knowledge of FND and the use of ISTDP as a treatment. I encourage you to be on the lookout for the next conference and attend, as they are incredibly worthwhile experiences. In addition to treating many patients with FND during his distinguished career, Bill has devoted a great deal of time to training others. He excels at teaching and has educated all levels of trainees, ranging from medical students to faculty. In that role, he has supervised 29 postdoctoral fellows and taught over 20 graduate-level courses in psychology. Bill has received at least 12 awards recognizing his excellence in teaching and outstanding contributions to resident education. With that, I want to again thank Giuseppe and Mark for their leadership in sponsoring the Functional Neurology Lectureship series that we initiate today with a talk by our own illustrious Bill Watson, who is considered by his Epilepsy Center colleagues as the best psychologist in the world. Today, Bill will speak about an experiential, emotional-focused approach to understanding and treating functional neurologic disorders. Please join me in welcoming Bill.
Good afternoon. You stole some of my thunder, Mike, so I'll get rid of all my comments about Giuseppe. That's gone, that's gone. All right, so I do want to begin by thanking Dr. Erba and Mark Brzezinski for their contribution in establishing this important lecture series on such an important topic, one which has been historically so misunderstood and neglected. Our therapeutic approach to FND at Rochester is based primarily on intensive short-term dynamic psychotherapy. But before I do that, I guess I'm supposed to show you my financial disclosure slides, which are non-existent, and our learning objectives, which is to understand more about how symptoms arise in the context of blocked emotional experience, and to go over at least one approach to reducing the anxiety and tension that results from such blockages, and then understand 3 pathways of anxiety in the body and how that relates to the phenomenon of FND and PNA in particular. This is what Mike already covered. I'll keep going. ISTDP, I have found, provides the most comprehensive and robust explanatory model for understanding and treating FND and PNEA. According to David Perez, director of Harvard's FND clinic, Rochester is unique in having one of the only, if not the only, ISTDP-oriented FND assessment and treatment program in the country, in that we are cutting edge. Though programs like ours are rare in the US, leading FND treatment programs in Canada, the UK, and Europe employ ISTDP as a treatment of choice for somatic symptom disorders, as well as other psychiatric disorders. Okay, got to get the, here we go. So all of this talk about what ISTDP is, it really just means that we help patients discover what they feel and why they feel it, and to feel it deeply and not avoid it just because it's uncomfortable or even painful. So these feelings can be felt and processed and not just thought about or talked about, but felt and then released and resolved. As I hope to demonstrate, in many ways, ISTDP and related emotion-focused approaches hold as much promise as, if not more than, current cognitive behavioral models in understanding and treating FND in general and PNEA in particular. Indeed, there is substantial research support for this view, with benefits shown in numerous studies of ISTDP across a wide variety of psychiatric disorders in general, and across a wide range of somatic disorders as well. Studies also show massive drops in emergency room use following treatment with ISTDP for patients with somatic symptoms and for patients with multiply unexplained symptoms as well. Consistent with these findings is substantial reduction in medical costs for PNEA and for chronic pain, among others. Now, by far the most common FND presentations are functional seizures, with functional movement disorders next up in frequency. Today's presentation will focus particularly on the former. Treatment of choice for both is psychotherapy, but with the crucial addition for movement disorders of FND-informed physical therapy and occupational therapy, and for patients with functional speech disorders, disorders, then you also want to add speech and language therapy to that roster. So, how to understand the ways in which disrupted emotional processing relates to FND? To begin, we need to look at how emotions affect the body. Somatic symptoms are often caused by anxiety, triggered by rise of uncomfortable emotions, most often anger, which is the most complicated feeling for most people to experience, as it brings with it fears of injuring others or being injured. Now, it's true that love and sadness and grief can all be quite challenging as well, but for most people, these are less anxiety-provoking than the feelings of anger and rage. ISTDP posits that emotions can be understood as having three principal components: conscious recognition, the cognitive label, somatic experience, or the bodily manifestation of the feeling in the body, and a motoric manifestation, which you'll notice, all of us will notice most profoundly as the feeling is felt most intensely. Our body wants to do something, move. There's impulses and urges that we begin to feel more clearly the more fully we feel the feeling. Now, here are some examples of that. I'll let you take a look at that while I drink some water. So, for example, with anger, we experience a rising heat typically, and a sense of power, strength, and the urge, the motoric urge, is to lash out, attack, injure, or to fight off the attacker. If we're feeling glad and warm, love, we feel that warmth in our body, and an urge to move toward the other person, embrace them, touch them, be close to them. Now, even briefly experiencing any of these three components of emotional experience, whether it's conscious recognition, somatic, or motoric, can trigger anxiety, shame, pain, guilt, triggering somatic tension and FND symptoms, as these videos will illustrate. By the way, I want to comment that all of these videos are shown with the permission of the patients to use their video work with me and the teaching of healthcare professionals. Most of them are very enthusiastic about that. If any of you happen to, by any chance, know the patients being shown here personally in your personal life, please excuse yourself. The clips are all pretty brief. And there was to be no recording of any of the videos in any way to respect the privacy and confidentiality of these patients who have generously shared their experience here. All right. She wanted to tell her grandmother that she's no longer her grandmother. I reflected that back. Hey, you want to get rid of her. And her unconscious, I would posit, experiences that as wanting to kill or push her grandmother off a cliff, which becomes unacceptable to her, and she passes out in response. For this, I'm asking this person how the anger shows up in the body. She's able to very easily say that she feels angry, in this case with her mom. But when she begins to feel it in her body, she dissociates briefly, and you'll notice a slight twitch. And she has become quite upset because she hadn't had any of these for a while. With this patient talking about the abuse, sexual abuse by her cousin when she was young, just talking about it begins to put her in touch with how angry and furious she is about this. And then that triggers an event. Guilt about our feelings is a major reason we avoid them. This guilt fuels conflict. We feel what we feel, but we reject what we feel. So we succeed in getting away from the feeling that's making us feel guilty, but then we can wind up trapped without even knowing why. So even the very thought of letting yourself feel some anger sends her into a panic. Now we've seen that unwelcome emotional experience can arouse such tremendous anxiety that it can trigger somatic shutdown, dissociation, and convulsions, all of which erase awareness of unwelcome affect. This process is automatic and as involuntary as a headache from a confrontation. It's as automatic as hoarseness from choking back tears, or say, insomnia from anticipating a big presentation the next day. Bodily experience of these emotional states is automatic. Blocking them takes energy and brings tension and malaise. Now, there's a common sentiment in the field that there's no known cause or no known cure for these symptoms, although they can be treated. This rankles me whenever I hear it, because I don't see it that way. And I think this sends an unfortunate message and is based on, to my way of thinking, not fully understanding or not even understanding at all the emotional dynamics of these kinds of symptoms. I grant you that maybe no one size fits all in any explanatory model, so there are likely other contributing factors to other forms of FND, but the ones we see on the epilepsy unit, this fits very nicely. This model I'm talking about today fits very nicely. This kind of quote from the Kennedy Krieger Institute FND clinic website is pretty typical. The exact cause of FND is not fully understood, although research indicates that it involves brain areas that respond to threats and emergencies. Okay, well, we're getting a little bit close there, threats and emergencies. But I just don't think that, I think it's more understood than this might suggest, depending on who you ask, I suppose. So the current etiological models for FND are, the sort of former one was a trauma or stress-related model. And the more common, more frequent one, more current ones now involve suggesting that the FND results from a problem with the functioning of the nervous system, or it's a brain network disorder, a kind of a neurobiological explanation. Metaphors often used with patients are it's like more of a software problem rather than a hardware problem. Your body's fine, the hardware is good, but there's some glitch in the software. For non-computer savvy patients, an alternative is suggested it's like an out-of-tune piano. The piano is fine, it just needs to be tuned up. Or maybe it's explained as a disorder of predictive processing. An example is sometimes given that the functional limb disorder, with a phantom limb syndrome, there's no limb there, but the brain thinks there is. With functional weakness, functional leg paralysis, there is a leg there, but the brain thinks there isn't. So it's a mismatch in what the brain is looking for versus what signals are coming from the body, is one way of explaining it. Or to bring it back around full circle from point number 1, point number 5, a disorder of emotional processing, sort of, in my view, recharacterizing Model 1 in more contemporary terms. Either way, 1 or 5, I'm good with. It involves feeling versus not wanting to feel it, or an analogy often used with patients on point number 1 is a pressure cooker. Like the stress is building up inside but doesn't have a release, and then the lid blows off. So what we want to do treatment-wise is sort of get that release valve working, because the release valve in your pressure cooker got clogged, and it's not allowing any release. I think that has some merit. Now, all of these models have their flaws. The idea that it's trauma or stress-related has been met with patients saying, "But I'm not under any stress," or don't have a history of trauma, and at least half of them, research suggests, don't have a history of trauma. I hasten to add. Well, it varies from 25% are traumatized to 75% are traumatized in their history with FND. So I'm going to just split down the middle and say 50%. So they don't get how this could be stress-related or because they don't feel they're under any stress, or at least not any more stress than they've ever been under, and they didn't have these years ago. The problem with the functioning of the nervous system or a brain network disorder, a software hardware, that can be confusing to patients and don't know programming or don't know piano tuning. This sort of breeds helplessness. They don't know what to do about it. A disorder of predictive processing, what? That, what are you supposed to do with that? Some of these explanations to me soothe the explainer more than benefit the explainee. Even the last one, a disorder of emotional processing, you can run up against a patient's response of, I don't like processing my emotions. I don't like talking about my feelings. That's fine. That leads then to anxiety and avoidance, or avoidance and anxiety. But at least it's a start. You've got a toehold there when they're saying, I don't like processing or talking about or feeling my feelings. The reason that the stress-related explanation can be so confusing is that much of our affective experience lies outside of awareness for many practical reasons. We have a lot to do. We can only focus on certain things. We also have our own history of how we've been trained. Sometimes we were traumatized, so we were trained not to pay attention to how traumatic things work because there was no recourse to resolve or soothe that trauma and the resulting experiences we have. Or we were trained growing up that you're the one in charge, you're the parentified child, you're the oldest sib, don't pay attention to what you want or need, you're busy with everybody else. You become an over-functioning caretaker, and you can't pay attention to what you need if you're gonna pay attention to what you need to do. So pragmatically speaking, it works to just shunt things aside. Most of us don't want to get up in the morning, but we get up anyway. We shunt that aside. You can't always focus on things that you're feeling. But as a result, then it can get confusing when you don't know what you feel or you don't know what's bothering you. Experientially surfacing relevant aspects of this dynamic clarifies the embodied connections between mind and body that helps begin to bring some insight into what's going on for these patients. All right, so she went from not having any idea of why these might be happening now to very quickly tuning into something that's very activating for her, that is now, it is in the present. And it begins to start manifesting somatic responses that also then are consistent with the kinds of seizure prodrome, broadly speaking. So it's beginning to get a toehold in what's going on emotionally for her that's giving rise to these symptoms. So emotions bring anxiety, bring defense, bring suffering in our mind, or emotions, depression and anxiety, panic, OCD, all kinds of things, or our relationships, irritability, fighting, distance, shut off, or in the body. So understanding how unconscious anxiety manifests somatically clarifies PNEA and FND and offers clear treatment implications. We saw above in these previous videos that uncomfortable, disavowed feelings can cause considerable anxiety as they begin to emerge. So let's see how that flows in the body and what to do about it. Why do uncomfortable feelings create such somatic issues? So in ISTDP, it's posited that there are three primary pathways of anxiety, going into various systems in the body. One is the voluntary muscle system, which results when you're tense and anxious in clenching, tightness, intercostal stress and sighing. When running out of control, it leads to chronic pain, swallowing difficulties, rigidity, convulsions. Those voluntary muscles start taking over and getting dysregulated on their own, flooded with anxiety. If you've ever been flooded with anxiety like I am this morning, you notice it's hard to calm down the tension in my throat just by thinking about it. I can't just tell myself, well, this is psychosomatic, functional, just relax. Okay, I can try to relax in other ways and hope that calms down, but we don't have direct control over these things. They take on a life of their own, which is why it's so debilitating and so infuriating and so unhelpful to suggest to patients that they're doing this on purpose, for attention, for looking. What's wrong with attention anyway? None of us get enough attention. I don't get enough attention. You don't get enough attention, admit it. There's nothing wrong with attention and needing attention. It's a good thing. Okay, so anxiety can also go into involuntary smooth muscles, such as the GI system, and my anatomy is not as sharp as it might be, but there's lots of other smooth muscles all over the body. Vasoconstriction is a smooth muscle. You get especially GI, nausea, vomiting, these kinds of things, butterflies. It can go into cognitive or perceptual disruption. The mind begins to drift, the person starts to float away, begin to be not present any longer. You can experience brain fog, you can't focus, your mind goes blank. This will happen when patients are talking with you and you go, wait, what was the question? Until I began studying this, I just answered the question. I just repeated my question for them because we all kind of know that happens sometimes. We just forget that. But now I began to say, well, did something happen just there? Before you ask, what's the question? Did your mind go something? Yeah. And then, at least 3/4 of the time, there's some point of anxiety that popped up that in what I was asking that made them lose the question. Dissociation, passing out, or that's the cognitive component. The perceptual, you get blurred vision, muffled hearing, numbness, and then you can go into motor conversion entirely, where the body completely shuts down with weakness or paralysis. What we're shooting for is healthy emotional processing. Emotions want to be metabolized and resolved via the emotional channel, whatever that is, but bear with me here. I can't, point to the neurobiology of it, but we all kind of have an instinctive notion of what it is to feel things on an emotional level. And that's where feelings want to go. That's where they need to go in order to be metabolized and resolved, versus the cognitive or the somatic channel. Those are less efficient in terms of resolving emotions, emotional difficulties, is inefficient. You can't really think your way to resolving feelings, not really. You think you can, it can feel sort of like you can, but it doesn't really go all the way down. When negative affect is overlooked, ignored, avoided, blocked, buried, disowned, then somatic tension and energy rises. That energy has to go somewhere. Unexpressed emotions will never die. They are buried alive and will come forth later in uglier ways, said Sigmund Freud. Freud was right, by the way, about so much. And then he had to go and get wacky. By the way, seriously, when I began doing the stuff that I'm talking about today, I said, oh my God, Freud was right. I get it now. Here I was like 30 years into my career. I've studied psychoanalysis, all that stuff, blah, blah, blah. So much jargon makes my head hurt. And yeah. But then I start doing this stuff. It's like, oh, that's what he meant. That's what that is. Amazing. Yeah, okay, we're talking about channels of feeling versus cognitive versus affective. So this is an example of a patient where we're looking at the cognitive channel versus the feeling channel. You could explain this intervention, by the way, as very cognitive behavioral. We're looking at the thought, right? Nothing wrong with cognitive behavioral therapy, that's fine. These all things you can map a lot of what I'm talking about today onto CBT, and a lot of what good CBT therapists do is a lot of similar things I'm doing here. But one of the things I want to point out here is the experiential nature that in addition to having her notice the fact that she relaxed when she had that thought, we sat with that. I invited her to sit with it and notice it. And then when she did that, things began to happen on the emotional channel, began coming up. The emergence of strong emotions can result in anxiety, pain, shame, or guilt, all of which trigger automatic reflexive defenses against experiencing the painful affect, which minimizes, sidesteps, or shuts down affective experience. The anxiety and tension then become somatic rather than emotional and can result in somatic symptoms, including seizure and loss of motor control. As a rule, the more threatening the emotions and the more completely they are blocked, the more prominent and problematic the somatic symptoms. In the IESTDP, we look to help the patient see their feelings, simply by asking what they're feeling quite often, help them see how they're avoiding those feelings and what that costs them, inspire them to consider not doing it, invite the dropping of the defense, ask them how the feeling is experienced somatically to deepen their experience of it. And we want to distinguish them when they give a response, whether what they're describing somatically is a somatic sign of feeling, like warmth, heat, boiling, energy, when they're describing anger, versus anxiety about the feeling, which will describe a sense of pressure, pain, tingling, muscle tightness, clenching, weakness, numbness, nausea, dizziness, blurred vision, tenderness, etc. So they say, I get a knot in my, I'm angry, I feel that like a knot in my stomach. That's a sign of anxiety about the feeling, not the feeling itself. We want to reduce the anxiety if necessary to help them hang with there, because there has to be some degree of anxiety tolerance to move towards anxiety-provoking feelings in order to get them to resolve. So we want to help them with that. And then, if they can, once they get to the point where they can feel the feeling without undue anxiety, we look to explore and release associated urges through imagined portrayal of the impulse. There's a 15-year-old I'm working with who's mad at her boyfriend. They've had it in kind of an enforced distance between them, and they can't talk to each other for external reasons. But now they're both jealous and anxious and insecure. She's all pissed off and sad about it. Let's look at what some of the results are of doing this kind of work. This is with a 10-year-old whose father abused and tortured her mother in front of her when she was younger. The father's no longer on the scene. Out of the mouth of babes. The patient that was made a lot of progress in not having seizures and beginning to feel her feelings, and now she expresses some grief about where she's been in her life historically. This 15-year-old that we saw earlier, when I met her, she was having between 3 and 10 seizures every day at home and at school. Couldn't complete a day at school. Had been going on for months. By session 16, she was so excited to report that she hadn't had any for a couple of weeks. So we have all of 4 minutes for questions. The floor is open.
There's one from Zoom, but let me first ask mine. So is your entire job to get people to learn how to feel their feelings?
You could say so, yes. The problem is that there's so many things that get in the way of that. We block them without realizing we're doing it.
I didn't say it was easy.
No, yeah.
So the question from Zoom is, how does your framework understand defense and resistance?
Defense and resistance? Oh, yeah. Well, there's the things that block the feelings are the defenses. And the commitment to staying blocked is the resistance in some. So some patients are not ready to give up the defenses because they get too much assistance from them. Like you know, as somebody once said, to be deprived of a crutch is very, very difficult. Winnicott said, and that's a different point. Never mind. Other questions? Yeah.
First of all, thank you very much for this. I'm a longtime fan of ISTDP, although cannot perform it adequately myself. I am curious, with your leaning towards engagement with thoughts and feelings and being able to identify and process our emotions, do you have thoughts, feelings, and reactions about mental health, calling ourselves behavioral health?
No, not really. Never thought about that, but it's interesting. Maybe I should. We should talk. Oh, well, you're asking about the defense mechanisms and how we pointed out. Well, if they're doing that persistently in the meeting, I'll point out, do you notice that whenever I ask you, blah, 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 you change the subject, or you look away, or you say, or you go helpless or weak. What's going on with that, do you suppose? Are you interested in understanding more about what feelings are coming up inside of you that are giving rise to all this tension and bodily anxiety that are creating all these problems for you? So we don't point out every single defense, because plenty of defenses, like you saw in some of the work that I did here, if you just kind of ignore them, the patient keeps going. It's when they start to block the process, then you have to point them out and work with them. You don't want to do that, though, if they're not blocking the process in any substantial way, because that just sounds like you're nitpicking and will be interpreted as critical or attacking by the patient. Yeah. Yeah, Mike.
Another question from Zoom. What recommendations do you have for patients who don't have access to someone for therapy for their FND due to cost, distance, or availability of providers?
Yeah, that's a challenging one. This is one of the things that we contend with here, which is one of the reasons I'm very invested in trying to do training and let people kind of get more familiar with these patients and how to understand them. Some providers, some very skilled therapists are afraid of patients with somatoform disorders because they feel like ill-equipped. I don't have a quick answer for that. Zoom is now the thing. There's some resources online. There's also resources, books. For chronic pain, for example, Howard Schubner's book is a workbook that patients can work with themselves to try to work on these things.
So I think we're out of time. So I want to thank everybody for joining us at the first inaugural Erba Przinski Functional Neurology Lectureship. Thank you all very much.